Cervical radicular syndrome, or CRS, occurs when the nerve roots exiting the cervical spine become irritated or compressed. For the patient, this internal impingement usually manifests as radiating pain or paresthesia felt distally, often all the way down to the elbow and hand. Identifying the source of this pain presents a unique physical challenge. A clinician must diagnose a deep structural pathology hidden inside the spinal column, using only the external manipulation of the patient's head and limbs. An accurate diagnosis without advanced imaging requires a specialized framework. This framework relies on two distinct physical tests that apply entirely opposing biomechanical forces, generating completely opposite statistical strengths. The first pathway is the upper limb neurodynamic test 1, which utilizes mechanical tension to rule the condition out. The second is Sperling's test, which utilizes mechanical compression to rule the condition in. Relying on either test in isolation creates severe diagnostic blind spots. By pairing these specific opposing forces, a clinician builds a rigorous, statistically sound assessment. The mechanics of these physical tests are dictated by the underlying anatomy of the 7 cervical vertebrae. As the spinal cord descends, delicate nerve roots branch off, emerging through narrow bony openings called intervertebral foramina. For cervical radicular syndrome, we focus on the median and interosseous tracts originating from the C5, C6, and C7 nerve roots. When a structural defect, like a herniated disc, bulges into this space, it presses directly against the adjacent root. To confirm this exact point of interference in a clinical setting, we must mechanically provoke it. We can either stretch the nerve tightly against the bulge of the disc, or we can squeeze the surrounding bony architecture even tighter around the nerve. The physical constraints of the cervical spine act as a strict blueprint. They dictate the precise joint angles required to effectively apply those physical forces. To assess the mechanosensitivity of these neural tracts, we first deploy the Upper Limb Neurodynamic Test 1, or ULNT1. The process begins with the patient lying supine. The clinician initiates the sequence by actively depressing the patient's shoulder girdle, anchoring the proximal end of the system. The limb is then carefully positioned. The clinician abducts the shoulder to 110 degrees and sequentially extends the wrist, the fingers, and the thumb. Next, rotational tension is added by supinating the forearm and externally rotating the shoulder joint. With the arm preloaded, the clinician applies the primary dynamic provocation, slowly extending the elbow until the patient reports a reproduction of symptoms. If symptoms appear, a structural confirmation step is required. The patient is instructed to laterally flex their neck away from the tested arm. These external joint positions calculate out to a very specific mathematical requirement. Each angle is deliberately chosen to eliminate the natural slack in the neural tract. Locking the arm joints physically winds up the neural tissue. Extending the elbow acts as the final lever, pulling the median nerve completely rigid. Finally, bending the neck away maximizes the tension vector directly across the structural impingement. Ultimately, ULNT1 operates as a highly engineered mechanical tug-of-war. It is designed to expose even the slightest baseline irritation anywhere along the C5 to C7 tract. This data table illustrates the clinical power of that tension vector. Multiple studies demonstrate that ULNT1 possesses exceptionally high sensitivity, reaching up to 97% in the Wiener clinical prediction rule. Sensitivity measures the probability that the test will return a positive result when a patient truly has cervical radicular syndrome. This yields the diagnostic heuristic, SNEN-out. When a highly sensitive test is negative, it effectively rules out the condition. If applying maximum mechanical tension to the nerve root fails to reproduce the patient's symptoms, the physical probability of a meaningful impingement is effectively eliminated. Due to this high sensitivity, ULNT1 serves as a mandatory screening tool. It cleanly clears unaffected patients, ensuring they are not subjected to further unnecessary diagnostics. Once a patient returns a positive finding on the tension test, the clinician pivots to Sperling's test. This applies the exact opposite physical force. The patient sits upright. The clinician steps behind them, guiding their head backward into passive extension. The neck is laterally bent, crucially directed strictly toward the affected symptomatic side. Finally, the clinician applies the trigger mechanism. Axial compression. Firm, steady overpressure is directed straight down through the crown of the patient's head. Looking at the internal architecture, extending and bending the cervical spine significantly decreases the open space within the intervertebral foramen. Driving axial compression through that narrowed space applies immense local pressure, directly pinching the affected nerve root. Sperling's functions as a localized mechanical vice, recreating the exact physical impingement responsible for radicular pain. This table reveals a completely different statistical profile. Unlike ULNT1, Sperling's trades sensitivity for remarkably high specificity, peaking at 95% in the Shaw data. Specificity indicates a test's ability to correctly identify true negatives. It measures how effectively the test avoids generating false positive results. This gives us the clinical heuristic SPIN. A highly specific test, when positive, rules in the condition. Because the mechanical compression of Sperling's is isolated entirely to the cervical root, a positive symptom response confirms the pain is radicular, reliably ruling out peripheral nerve issues. Sperling's test lacks the broad sensitivity needed for screening, but its targeted precision makes it the optimal confirmatory tool once cervical pathology is suspected. Evaluating a patient using just one of these mechanics yields incomplete clinical data. True diagnostic accuracy requires running them in sequence. This sequential algorithm combines the strengths of both tests. Step 1 always begins with the high sensitivity of ULNT1 as a mandatory screen. This creates our first critical decision gate. If the tension test is negative, the probability of CRS is structurally eliminated and the assessment stops. However, if the tension test is positive, the clinician must immediately proceed to step 2, Sperling's test. Because ULNT1 casts such a wide net, it can easily trigger false positives from peripheral nerve sensitivities. Applying the highly specific axial compression of Sperling's test effectively filters those false positives out. Passing through this final gate secures the diagnosis. The tension test proves a neural sensitivity exists, and the compression test confirms the cervical root is the source. Executing an orthopedic test correctly is a baseline skill. Clinical mastery is knowing exactly how the underlying physical forces of tension and compression dictate the test's mathematical reliability, and knowing precisely where to place it in the diagnostic sequence.